Hi, this is Dr. Matt Emmons, Medical Director of Quality Improvement at LA Care. We're just getting set up here. We're kind of keeping an eye on people that are signing in, but we will be beginning shortly. Matt Emmons again. I'll go ahead and get started because we've got a lot of material to cover, and some of this is kind of background at the beginning, but we don't want to lose any time. There is this is what I call kind of our heavy-duty WebEx for webinars. Everyone is muted right now, but there is a chat box at the lower portion of your screen. If you're having trouble hearing, or if you can't see the screen, if there's a problem, let us know by chat, and we'll address it. At the end of the webinar, we'll answer questions using that chat function, and if we don't cover everything, we'll follow up afterwards. We are recording this webinar, so it'll be available for future reference. We're keeping track of the attendance, and actually this program even tells you how long each participant was online. So we'll be following up on that by IPA. We will also send a copy of the webinar after we finish, and I already mentioned the questions, the chat function, and the being able to message if you can't hear. So let me move to the next. This is our agenda, and the presenters from LA Care. Asal Sapasi, our Director of Quality Improvement, is out ill today, so I'm going to be presenting her function. We got some people kind of coming and going in the room here, but I want to keep going. So I'll be doing the intro in the background. Grace, do you want to introduce yourself?
Hi, I'm Grace Kim Crofton. I'm the Director of Quality Performance Management and responsible for HEDIS reporting.
And then Hanuk Solomon from Provider Incentives will be doing talking about the Provider Opportunity Reports. I'll be doing a SAL section on CG caps, and then the QI interventions, basically the remainder of the webinar. So again, welcome everybody. Actually, these things we already covered. I do want to emphasize that this is the home stretch. This is probably the most critical time of the year to impact HEDIS 2017 or measurement year 2016. I also want to mention that we are working on a end-of-year strategy, and we're going to we do need your assistance on it, and I'll be talking more about some of the things, but it's evolving very rapidly. But Dr. Carter is very concerned about our HEDIS scores, and we really need to do everything we can to turn things around. So we'll be talking about some of that as we go. And here's some background to kind of give you an idea. Not only is HEDIS critical for Medi-Cal and for auto assignment, things like that, but it's very critical for our accreditation status. And you can see here from 2014 through 2016, Our HEDIS numbers are not great. Those definitely need to be improved upon, but if you look at what's gone on with the CAP surveys, our scores have particularly for 2016, has really dropped. So member experience is one of our priorities, and we'll talk about some of that as well. But really wanted you to be aware of that because it has a major impact on our accreditation. Our next survey is coming up in 2017, so these results are going to be really critical. Okay, Grace, do you want to start off on the HEDIS piece?
Okay, hi everyone. I will very quickly go over the external accountability set that was just released by the Department of Healthcare Services and some changes there you may already be aware. They are eliminating the annual monitoring for patients on persistent meds, the digoxin. This is one of 3 of the persistent meds monitoring measure. Although they are eliminating this, just keep in mind that it is still an accreditation measure, so it's not in the state EAS set, but it remains an accreditation measure. Same thing with weight assessment and counseling. They're eliminating the BMI assessment. So we have just a nutrition and physical activity assessment. However, BMI assessment is still part of the accreditation set. So continue to take the BMI and report it completely. They are replacing the medication management for asthma with asthma medication ratio, and this is a ratio of the controllers to total asthma meds. I think 0.5 is compliant, ratio of 0.5. So we will be reviewing this a little more closely and strategizing around EMR. Dr. Emmons already.
Well, yeah, and unfortunately, most of our interventions were all designed with MMA. It really should improve both, so I don't think that's a real problem. And we had actually flipped our POR and took off AMR. so we're going to have to adjust to this. And of course, they made this retroactive to the beginning of this year. So, but we'll deal with it.
Adoption of, so HPV is now folded under the immunization for adolescents, so it's combined, so the HPV is now combo 2, combo 1 remains the meningococcal and the tetanus, diphtheria. Screening, now they added this other measure that is going to be pretty involved, and it's pretty new to all of us because this is not a HEDIS measure. It's called Screening for Clinical Depression and Follow-Up Plan, acronym is CDF. It's essentially whether or not you are assessing your members 12 years and up for depression, and if there's an evaluation and a follow-up plan. So we're going to look at PHQ-9s, Beck scales, other.
Yeah, this one surprised me quite a bit because, but it is evolving as a standard, and we're going to have to deal with it.
Breast cancer screening. So this is part of the accreditation measure set. So we've always reported on breast cancer screening. However, now it is added to the external accountability set, and you will note that both breast cancer screening and screening for clinical depression and follow-up, these are not held to the minimum performance level since they are new measures for measurement year 2016.
Yeah.
I'm going to just review the auto-assignment measures and how we have been trending over the years. So this is overall Medi-Cal performance, so all our plan partners combined, so Kaiser, Anthem, Blue Cross, and CareFirst, and Department of Health Services. You can see that comprehensive diabetes care, it's actually the HbA1c testing, and you can see that over the years, we've been going up 3 percentage points year over year, so trending favorably. Our goal for 2017 is 91%, if we can attain that. Well-child visits 3 to 6 years, and we've been trending favorably there too. Just inching up. Controlling blood pressure, this is all about charts, and leaving no stone unturned, chart pursuits, all providers who may have rendered a service for that member during the measurement year, and so you can see that we're trending. We have been trending up on these 3 measures. On the other hand, for childhood immunization combo 3, so it's all the antigens except for rotavirus and Hep A and influenza. We have had a decline, 4% decline from last year. So there was a significant improvement between 2014 and 2015, and then a decline. Cervical cancer screening, also a decline. New members, because it's a 3 to 5 year look back, much of this decline is due to data gap. We just don't have the member service history dating back 3 to 5 years. On prenatal postpartum care, timeliness of prenatal care, this is a statistically significant decline, 8 percentage points. All our plan partners, everyone, all entities, there was a significant decline here.
And that's one that's very difficult for us at the health plan level. It's very challenging to identify those new pregnancies. So anything that you guys can do to help with that, we really need all the help we can get.
Yes, please share with us if you can identify them early enough to get them in within the first the first trimester or the 42 days of enrollment. Be great. So overall improvement. So by significant, we mean statistically significant, not by chance. So we've had significant improvement on the eye exams. We've been mining the VSP data, reviewing all the eye exam negative cases, and working with our vendor. And if you have, if you provide eye exams, if you provide eye exams on site, just let us know. Comprehensive diabetes care, monitoring for nephropathy. You can see we've had some increases on 7 to 11 and 12 to 19 for children and adolescent access to PCP, antidepressant meds management, and appropriate treatment for children with upper respiratory infection. This is for not prescribing antibiotics when they are diagnosed with URI. Declines in 5 other measures. So BP control for diabetic care. Please look at ways to, use the CPT2 codes for BP control. Use of imaging studies for low back pain. We don't want to use imaging studies for low back pain. Children and adolescents 12 to 24 months and 25 to 6 months, and then, of course, timeliness of prenatal care. So we were at the 90th percentile in 2 of the measures. We would love for this to go up to maybe 6 of the auto assignment measures for next year, maybe 90th percentile for some auto assignment measures. The monitoring for nephropathy, we were quite high, and HPV, which is now folded into adolescent immunization. So I think this all goes to illustrate that we really need to work in partnership with our PPGs to identify members in time for timeliness of prenatal care, postpartum care, need to continue working on digoxin even though it's no longer part of the EAS set. It is part of accreditation. We will have work groups around asthma medication ratio, follow-up care for children prescribed ADHD medications, Combo 10 accreditation measures, so any way that we can improve rates on rotavirus and influenza and Hep A, appropriate testing for children with pharyngitis, and then the diabetes screening for schizophrenia, bipolar disorder using antipsychotic meds. And if you need additional information on that, please reach out to HEDIS off.
So this is worrisome, just that volume of, and you can see some of those measures, even though we had improvement, we're still below the 25th percentile. So this is, we really need to turn this around.
So specifically, those measures, the childhood immunization, Combo 3 and Combo 10, prenatal care, and cervical cancer screening. I would say those are measures of focus for all of us. I'm going to go into the HEDIS resources and just let you know just how there's a wealth of information in this page. You can see, if you go into the lacare.org, this site, you can see that there are presentations and trainings, there are videos, 6 steps to HEDIS success, and there's a video that's on the HEDIS specifications, HEDIS Made Easy with narration by Dr. Katrina Miller, Medical Director for Informatics, algorithm for cervical cancer screening, and Dr. Emmons will go over this, but you can see that there's HEDIS Made Easy, Office Manager Guide, HEDIS handout, and then here we have all the measure criteria along with the value set directory. So all the codes that are used for HEDIS reporting is in this value set, and we will be updating this for HEDIS 2017. So if you have, and we will also add another tab for any announcements and memos, specifically on supplemental data submission. Many of you, PPGs, are submitting data directly to us, so we will include our memo and the file specifications there. And I think that's really it. I don't have any, I'm going to turn this back to Dr. Emmons.
Okay, actually it's Hanok. This is the provider opportunity report. So Hanok is our manager of incentives.
Okay, hello everyone. So I'll talk a little bit about the provider opportunity reports and gaps in care lists, and then one slide on our pay for performance program. And so the provider opportunity reports are a very important tool from LA Care's perspective on for our quality improvement goals. And so the first bullet point, this is the schedule for the PORs this year. You should have received the first batch around late July. There's going to be another set of provider opportunity reports available within the next 2 weeks. So be on the lookout for emails for those. We're going to send them out again in November, and then one last final look at 2016 performance in February. And so just a little background, provider opportunity reports are a tool that we use to communicate LA Care's priorities. And so there are mid-year HEDIS performance reports that you can utilize to track and monitor your progress throughout the year. And so from year to year, there are some variations in our priorities, and so some of the measures will drop off and some will be updated and changed. And so in 2016, we removed CDC control less than or greater than, or less than or equal to 9 to less than 8. We added MMA 75% and added colorectal cancer screening. We removed ASM, et cetera. And so one important thing to realize is that to get your gaps in care list, AKA the member detail, which shows all of the members that have been compliant or non-compliant to date, you can get them through LA Care's provider portal, and that is the link. And so once you log in, it's under the report section, and then there's a folder for provider opportunity reports. If you've never utilized or gotten access to the provider portal, you can get access by contacting our LA Care Provider Relations Department. And so that email is it's providerrelations@lacare.org. And so you can get the PORs that way. In addition, you can also contact our team's email. It's that incentive_ops@lacare.org. And we'll also send you the emails or the provider opportunity reports through secured email.
So it's really important that you make sure that your PCP practices know how to access that member level detail.
Yes, and so in addition to, we send out the provider opportunity reports to you guys, the IPAs and medical groups. we also send them to PCPs as well, so they get the reports too. They are mutually reinforcing. You should be working with them on filling those gaps in care. And so the final points on this slide, they're used essentially for all measures, again, to track your progress throughout the year and to check for missing data capture. The first couple of reports that you received in the year, the July and September reports, those should primarily be used for member outreach. And as you'll see on the next slide that I'm going to go to, these reports do come with a caveat that there are data lags, and so that we do want to stress to you guys that not to be too worried if you're not seeing the data in the earlier reports. Encounter data, they're known to lag, up to 3 months, and in some cases even up to 6 months. So again, we want you to truly use the first couple of reports to do the member outreach. When you get the gaps in care list, bump it up against your own tracking system, against your charts, and if you see if the member has not come in, then using that report to do the outreach, call the members in and get them in for those services.
And if you look at that schedule, just realize from a practical perspective, this September POR that's going to be coming out in a couple of weeks is probably the most important for member outreach, because if you look, the next one's not going to be until November. From a practical perspective, it's hard to get patients in that period of time. So this one is really going to be critical.
Mm-hmm. And then, as we're moving along, the last report you'll receive early next year, around mid to late February, that one's going to be primarily looking to fill in, data gaps. And so, it's retrospective, and, for those measures that that you provided the services and submitted the encounter reports, the encounter data, it's vital that you work encounter error reports. There'll be opportunities to submit data via supplemental data, et cetera. And so you can reach out to us and ask us about that process.
Yep. And one of the things we're exploring as part of our end-of-year strategy is that, and actually would suggest on your member outreach, particularly for the September, or if you're working with the July, is it may be best to focus first on those members that have a relationship with the provider. And they're, first of all, more likely to have accurate contact information, whether you're doing it or whether the PCP practice is doing it. We are looking into ways that first of all, that we can identify those members that, according to our records, don't have a relationship, and then we're going to look into how we may be able to support in that member outreach, because it's a little bit different. So you should be hearing more on that strategy. This is something that's evolving pretty quickly, but I think from your perspective, it's probably best to know that it may be, as far as prioritizing, it may be best to start with those members that already have seen their PCP and have some kind of a relationship.
Mm-hmm. And so, again, as I was mentioning earlier, the POR does come with the caveat. It's vital that you interpret the data in the context of time lag. Again, the encounter data, it's an imperfect process. There will be data lag. And so some of the measures which we've listed out here, I won't go into detail on all of them, but these are the measures that we want you to, in addition to using the POR, to explore alternative methods of interventions. For instance, for childhood immunizations, we want to make sure that you're emphasizing with your providers to utilize the care registry, to add data there. We do downloads and we do extract data there for our HEDIS hits. And so, you'll see the other measures as well. They're listed, the factors impacting member outreach.
And this kind of helps, I think, again, on prioritization to make sure that both the PPGs and the practices prioritize where for member outreach, the ones that it works best are like the prevention screenings, those type of things. It's easier to see that whether the service has been done and to get them in. So I'd prioritize those measures, and then kind of, like Hanuk said, kind of look for other ways to impact some of these other measures where it doesn't work as well for member outreach.
Okay, and so on my last slide, I just wanted to briefly speak about LA P4P, our Pay for Performance programs for our IPAs and medical groups. The reason why we have the program is, number one, we want to recognize and reward all of your hard work in, providing quality care for our members. The program, there are two opportunities or two ways to do well in the program. One is by what we call outstanding performance or attainment, which is your individual performance relative to other PPGs within LA Cares Network. And then if you're not performing as well relative to the network, the other way that you can do well in the program is by demonstrating significant improvement year over year. So if you start off pretty low, but then you do make some great strides, then you can do well in the program. As you see in the third bullet point, you do not have to sign up. As long as you have 2,500 or more Medi-Cal members, and that's across all health plan partners, then you automatically qualify for the program. Interesting point, the fourth bullet point, LA Cares participated with the IHA, the Integrated Healthcare Association, on a collaborative amongst other health plans that do P4P and Medi-Cal within California. And so this collaborative, the whole aim of it was to standardize the measures in Medi-Cal P4P. And I want you guys to know that LA Care is fully aligned with the IHA Medi-Cal P4P core measure set. And again, the idea behind this initiative is so that we come up with a set of standards and metrics that are unified and that you don't have competing quality improvement priorities. The fifth bullet point, good news, the measurement year 2015 payments will be going out soon. We're currently analyzing the data and working on our scoring and payment calculations. We're hoping to get those payments out distributed after another couple of months, so around November or so. And again, that last point, success equals better care plus better data. It's vital that both are done. From our perspective, it's a lot of times it's hard to see in the data whether improvement was a result of better care or if it was a result in better data. So we need both. And actually, this is the connection with the POR. And so as you're getting these provider opportunities reports mid-year and you're tracking your progress and you're addressing gaps, it will improve your performance in the P4P program, and then you'll see an increase in bump in your payments.
And I would just like to say success is better care and better care experience, member satisfaction.
Yeah.
Yes.
Yeah. And the other thing I want to mention, too, is really, I think one of the key messages here is encounters, encounters, encounters. As Hanouk mentioned, the data capture is a key piece, really emphasizing to make sure that those providers are submitting as complete and accurate encounters as possible. That's probably the best way they can impact their performance and our performance.
And I'll pass it over to Dr. Emmons.
Okay. I'm going to talk, building on that member experience aspect, and we already showed you that our CAP scores have been miserable. This is the key to really gaining insight into member experience at your group level, your IPA, PPG level. So you can see that, again, it's the consumer assessment, so it's their perception of the healthcare provider system, which includes the health plan as well. So it's addressing access and care delivery, service, and the health plan at the IPA level. We conduct it every other year, and there's an adult and a child version. And I don't recall exactly when they were sent out, but you should have received 2 reports, one summary level, and then you should have received the more detailed results.
And so these were sent out around March, April, earlier this year.
So I want to touch on some points to kind of give you an idea, if you aren't familiar with it, why you should be familiar with it, and how it can help you prioritize your interventions to improve member experience. These are the individual composites or ratings you can see. Getting timely appointments, which is really access related, provider communication with patients, the helpful, courteous, respectful office staff, providers rating as a provider, or patients rating the provider, coordination of care, health promotion, the patient's rating of health care, which is a very key piece, getting needed care, which is also an access-related measure, and then patients' rating of the health plan, which is certainly influenced by their experience in the office as well. If they're not having a good experience in the office, they're not going to think highly of the health plan. This is an example of timely care and service, really the composite access score. You can see, and did they receive their, okay, you should have received your number, and again, it's data that you already have, but this kind of gives you an idea of those IPAs or PPGs that are contributing to the overall member experience in a positive way, just looking at the average. Now again, because our scores are bad, that average needs to be higher in general, but you can get an idea of who's contributing positively and who's contributing negatively. So I think this is the key piece. That's the adult. This is the child, so very similarly, and the distribution isn't, the group rating is a little bit different, but make sure you're familiar with that and get an idea. And you can do the same thing looking at some of the other key measures, and I'll show you how you can prioritize interventions that will have the biggest impact. As far as the timely care and service, I think that, well, I don't know if this is in the summary or if this is in the detail report, but you can get an idea. This is an example of a group in timely care and service where you can see, even at a glance, you can see that the biggest opportunity is really urgent care, appointment for care needed right away. The others, you can look at the two lower measures, the regular aspect, more the routine visits is much better. So it kind of can give you an idea at a drill down level where you can have a bigger impact. Similarly, there's tables in your detailed report that gives you an idea of this gradient, this quadrant that gives you an idea of where you can prioritize your interventions. The left upper quadrant are those that your performance is low, and yet it has the highest yield to actually improve your score. So you can, and in this case, timely care and service and coordination of care are those two areas that will have the biggest impact. And then similarly across the quadrant, you can see the ones that you may be low, but may have a lower yield as far as impacting the score. So make sure, if you aren't already familiar with it, go back and look over those and see which areas your group really needs to focus on, and really help the provider groups understand that, which is the first point here. And the other is really working with your provider groups to make sure that they promote an entire culture of customer service. I see a lot of the grievances and on the back end and PQIs, and I can tell you a lot of them are related to referral management gone wrong. And so whatever you can do to improve that operations of referrals, that can really impact the members' perception of how well your group and the health plan. If it's not going well at the IPA level, they're going to blame it on the health plan as well. The other thing, I really hate to say it, but I see too many grievances that give very credible explanations of derogatory remarks that are made in the physician practice regarding Medi-Cal or the health plan in itself. Remarks like, oh, your insurance doesn't reimburse anything, things like that. That should never happen. My feeling is, and I hope everybody agrees, that a member, regardless of their insurance, needs to be treated with the same respect and dignity that any member with high-end insurance would be treated. So make sure your practices really understand that. And I think it may be more of an issue of those that have some Medi-Cal but maybe have a higher level of commercial, but it's something that everybody needs to understand, because some of the things I've seen are really atrocious things that were said that should never be heard by a member. And again, that's reinforcing negative member perceptions or creating negative member perceptions shouldn't happen. The other is really monitoring your appointment availability. Many of you are doing ongoing monitoring for that. And one aspect of that, too, is minimizing the out-of-office message during business hours. I can't tell you how many times I try to call a physician practice throughout the day and multiple days, and every time I call, you get the out-of-office message, and it goes to the exchange. You know, a member can't make an appointment if it goes to the exchange, so make sure you emphasize that to the practices as well. One of the things we're moving toward since January, our Appeals and Grievance Department has been tracking total grievances, and we will soon have the access-related grievances on a per 1,000 members per month basis by IPA or PPG. My plan is we're going to be able to correlate that with your CG caps, particularly the access-related ones, as well as your appointment availability surveys. So that will just give us greater ability to really reinforce, you know, across multiple data sources, the groups that are having the most problem with either total grievances, which affects satisfaction, or access-related issues. In the interest of time, I'm going to transition pretty quickly into our QI interventions. We are currently doing a rapid cycle process improvement project or program with through HSAG and DHCS. We're working with a key clinic, and what we're doing now is we're really trying to share some of the early findings and get that message out so providers can be aware of it, and hopefully so it's not just a long-term strategy. We can try to get things changing more quickly. And many of these aspects, some of the issues, we discovered that for CIS, the provider opportunity report is not effective for member outreach. Most of those kids that are turning 2, particularly this time of year, there's not that many left. If they weren't up to date in the first 12 months, they will probably, no matter what you do, they won't be up to date. And so really part of it is getting those newborns in as soon as possible after 6 weeks of age to get them a timely start and to keep them on track during those initial 12 months, which is the most critical time frame. We found that really scheduling follow-up appointments for that next dose, we believe, can have a big impact, particularly with the clinic that we're working with. So make sure that you prioritize appointment availability for those, many of those early follow-up doses are at least 4 to 8 weeks. And then the other thing we really meant, as already mentioned, is to use the care report. That really helps us with the data capture and really can provide essential, almost real-time gaps in care reports for the groups that are actually using it effectively. Get ready for Care 2 for current users, which I think they define anybody who accessed it within the last 6 months, I believe. The training's going to begin first quarter 2017. It'll be a much more robust software, and so we really want to take advantage of that. So if anybody who's not been using it, I advise get on it so you can get in that first round of training for Care 2. For CIS, the other thing is that we found that when you break it down at an antigen level, the DTaP and PCV were consistently for the last several years have been the measures that have been dragging us down. So again, I'm not going to go over in detail, but part of it too, if you look, that the PCV, if you don't get your second dose until by 7 months, 7 to 11 months in particular, then the guidelines say wait until 12 months and the third dose is final. If they don't get that fourth dose, they won't be HEDIS compliant. So you really have to aim to try to get that second PCV dose by 7 months to really reduce that risk of missing the fourth dose. So that's something to really consider. The other thing too, from a PCV perspective, that protects those children against systemic pneumococcal infection, and that first year of life is when they're most vulnerable. So that's really key. We developed this tip sheet that really goes over the things I just talked about. That will be posted very shortly on that HEDIS resource website that Grace showed you. And so make sure, I really encourage you to get this out in the hands of the providers so that they're aware of that. We're doing a project with lead screening, lead poisoning with children, which includes screening. This isn't, as far as not a high priority measure, but from a public health perspective, it is key. We've noticed that there are several spas that have a lower rate of testing and have a higher risk of lead poisoning. We've developed really a table or counter display that has tear-off sheets that the parents can take that gives them tips on how to reduce the risk of lead poisoning. So if you have particularly large pediatric practices or clinics that are interested in this, just send us an email and we can help get them set up. I hate to distribute it too widely and if they're going to end up in the trash. So really my preference is to distribute it to those groups that are interested in it and are willing to display it. And there's some other things we're doing with lead poisoning that will include a member intervention. Some other pediatric and adolescent measures, we really want to emphasize the AWARE guidelines for the appropriate use of antibiotics and strep screening. We'll be sending out again this year fax blasts because we're coming up for flu season. We're doing a number of interventions for chlamydia screening. And actually did, I thought, a very innovative targeted social media campaign that appeared to have a pretty significant response. It was not LA Care specific, but there was a good response of people actually clicking on the link and reading more information that included kind of a case history of a woman affected by chlamydia. So from your perspective, promote the AWARE guidelines. Make sure that groups are capturing, they're getting in their encounter data, they're capturing those point-of-care strep screens because those are ones we won't get through lab data. So again, it's a data capture issue. And then also for chlamydia, we believe the best practice that we've heard is probably from a workflow perspective, making sure that they just routinely collect urine, even prior to at the time the woman comes in from 18 to 24 years of age, comes in for an appointment, collect the urine and have it there available to kind of remind the physician to order that screening. Some of the things we're doing on the other maternal child interventions, we've got our Healthy Mom program that we're doing. And we're really promoting Text for Babies, so if you have an opportunity to do that, it's free for women to sign up for it, and it gives them very timely messages regarding different aspects according to their stage and their trimester in pregnancy. We also have been doing some outreach for a couple of groups, and we're talking to another group to add it, where we're getting notification of the hospital discharge date following a live birth delivery, and then we're reaching out to those members to plug them in to make sure they get their postpartum visit and know about our member incentive gift card. Call to action, again, this whole issue of identifying newly pregnant members. We need all the help we can get. Make sure you remind your practices, your OB practices in particular, that the standard is appointment availability for Medi-Cal is for a prenatal visit is within 14 calendar days. If you look at our compliance and our appointment availability survey, only 65% of the specialty groups, the OB practices, actually had evidence of meeting that standard. So that's worrisome. We want to remove all the barriers from women getting that timely prenatal visit. Another thing is ensuring that pregnant women can get their pertussis and flu vaccines from the OBGYN. That kind of goes to the point that I want to emphasize in general, we'll get to, that should not be putting the member in the middle of a referral process for routine preventive services. And I'll touch on that in other areas, but it's really important. And then also that facilitating that postpartum visit, whether it's done at the PCP or whether it's done at the OB-GYN, really help facilitate those visits. It's a narrow window, relatively narrow window, and it's particularly challenging for women who've had a C-section because they usually go in earlier and then they don't come back for the formal postpartum visit. So we need your help with that. You should have already received by email a copy of our CCS algorithm. This is actually based on a program that was successful at a site basis. So if you can get these out into the practice sites, we're hoping it will help. Part of the issues is that the guidelines for CCS changed a couple of years ago, and it's challenging with the variable time frames, whether it's co-testing or not. It's challenging for women to keep track of that, so this is really to help clinicians, particularly great, I think, for physician extenders to be able to keep in mind what the guidelines are. It's really aimed at primary care. Our feeling is if it gets to that area where you need to access the American Society for Colposcopy and Cervical Pathology guidelines, it's probably going to be more in at an OBGYN site. So these are really geared for primary care. The focus is on normal risk, obviously, because of that. And the other thing is, again, reminder is that the member should not be put in the middle of a referral, requiring a referral. By state law, according to the federal law, state regs, our contract with Medicare, you can't require a woman to get a referral to go to an in-network OBGYN. We don't care if you do it on the back end, if the OBGYN calls the PBG and gets a referral for payment, but don't put the member in the middle. And again, I've seen too many grievances where that referral process for routine preventive services, where it shouldn't even been happening, got in the way of the member getting the service that they needed, and also creating member dissatisfaction. This was the other form that we included in the email. Part of that is really making sure that members can easily understand which OBGYN practices in your network that they can access directly. And so this is one suggestion, and if you recall, we included a Word version. If you want to customize it yourself, that's fine as well. But the main thing is that we want women to have a choice, and that's part of the concern. We've talked to our member services, and previously member services were just telling members, call your PCP office. And my concern is PCP office may not be actually giving women a choice. If they want to go to an OBGYN, they have that right, and so, but they need to know which offices they can contact. We're doing some additional interventions, robocalls, member mailers for CCS, with a member mailing for colorectal cancer that was in collaboration with the American Cancer Society, and we're adding some additional things in our end-of-year push, but we just wanted to mention those. One of the key things on this, again, from your perspective, is again, don't put women in the middle of requiring referral. We believe that one of the best practices we've seen is for the PPGs that are currently working in collaboration with their diagnostic imaging centers to do member outreach. The big advantage is that they can schedule the appointment right then when they reach the member. In the survey we recently did, a number of practices were doing that. It's probably not too late, particularly if there's a couple of groups, RadNet and one other group, that's familiar with it because they're doing it with some of our PPGs. And so if you're contracted with those centers, look into it. You might still be able to do it even now. And actually that leads us to the survey results. We received 11 responses, and that was really represented over half of our MCLA membership. We're going to give a last chance for those groups that didn't submit by close of business September 20th, and we'll add that and update the statistics. You can see the top measures where member outreach is conducted is CDC, BCS, CCS, CIS, and again, makes me wonder what they're doing. If they're using the provider opportunity report, that's probably not the most effective way to do member outreach. And then the primary outreach was live calls and mailers. I think we had one group that reported using secure messaging. And then, again, 55% of the IPAs that responded are working in collaboration with their diagnostic imaging center. So that's really, we believe, is a key point and probably the best practices. Now that we have that, and particularly once we give you until September 20th, we're going to go back and look at rates for breast cancer screening and for some of the other measures to see how effective are those member outreaches and compared to those groups that aren't doing a member outreach. So we'll be able to really try to do more sharing of best practices with actual data. The other thing was the group's perceptions of which measures are most impacted by data gaps. You can see those CIS, W34, CCS, and HPV. That's pretty much what I would gather as well. I did want to mention we have noticed as far as our administrative data capture, there are a number of measures that have improved, and I believe probably CARE is the main reason for that on childhood immunization. And Hep B was one of those measures that it improved quite a bit in the last year. So only 27% of our responders or 27% of our responders do not use the POR. So that, again, that's probably the main, particularly with this next one, the main thing you can do to impact our HEDIS scores and expand partnership with specialty practices. I'm going to go over this really quickly, transition to care. If you recall, I mean, this year, and last year, we've been doing a QIP for CalMedi Connect. Previously, there was a QIP for Medi-Cal, and actually DHCS expects that we're continuing to address it. You can see what this is really all-cause readmission ACR. It's not risk-adjusted. For Medi-Cal, we adjust it based on SPD versus non-SPD, but you can still, the rates are still higher than we like. So in the call to action, keep in mind those things that we've already gone. For those of you that are also participating in CMC, you kind of know what these things are. Keep it in mind because we really need to improve reduce our 30-day readmission rates. And related to that, we're having a Transition of Care conference on November 5th. So we wanted to remind you of that. It's going to be multidisciplinary, and really hope that you can participate in that with any of the stakeholders in your practices or your IPA that impact or that are involved in transition to care. We have a list of contacts here for your reference. I'm not going to go over in detail, but we really want to make sure that you know how you can best contact. And most of these you can see, email is probably one of the best ways because those are continuously monitored, and we know who to point them to depending on what the given question is. So it's probably the most effective way to reach us, but also, I mean, if you'd like to call, you can do that as well. Also, we've included this was a last-minute addition as far as our data submission timetable. Grace, anything quick that you want to say about that?
We've distributed instructions in the file layout to all PPGs and plan partners, so please take a look, and if you have any questions, just email us at hedasops@lacare.org, and we will reach out to you as well. We will follow up. Okay, thank you.
Okay, that was a lot of material, and I mean, you're welcome to use your chat and submit any questions, and we'll address those. Or again, if you forget, just send an email to the general quality improvement, or whether if it's HEDIS related to the HEDIS ops team. We're looking now. There's a question about can LA Care collaborate with CARE to have mandated use of CARE. We're certainly working. We've had several meetings with CARE. It may be challenging to mandate it. I think at this point, the thing is that if somebody hasn't implemented CARE yet, with CARE 2 coming relatively soon, I don't know whether it's worth implementing CARE, the current CARE, at this stage of the game. That's something you just have to kind of weigh at a case-by-case basis. But particularly when CARE 2 happens, we will be pushing really hard and encouraging the groups to and practices to get their training, to get up and running on it, because it's really going to be much better. It has two-way communication with EHRs, and much more. When you consider the current software, I think is about 15, 16 years old, but it's still, even with that, it still can do quite a bit. Let's see. How can we give the supplemental report for HEDIS?
How can they submit the supplemental data for HEDIS?
Yeah.
They can upload to the FTP site or contact HEDIS Ops if this is your first time submitting, and we will walk you through.
Yeah, there's formatting things.
Yeah,
and actually, didn't you say that you were going to add a tab to the HEDIS resources that would have that information in it? So keep an eye on that, but in the meantime...
reach out to HEDISOps@lacare.org, and we will walk you through the process.
Yeah. Let's see. Oh, for CCS, do you have a sample letter that was sent to the OBs? Actually, it is going through, we made a few revisions, and it's going through the review process now. I'm glad you asked that. We will get that out to you as soon as it's finalized. It basically talked about the open access issue, and I don't have it in front of me, encourage them to be aware of which imaging, for mammography, which imaging centers the PBGs are contracted with, so they can basically just send the member with an order to the right place to get it completed. The other thing is make sure your imaging centers know about the not requiring the referral piece. Again, if they need to do it on the back end, do it on the back end, but we still hear stories of imaging centers you basically denying it and saying you have to go get a referral. We don't want to create that barrier. The challenge for us is that it's challenging for us to identify those imaging centers in our provider database. It's mostly by radiologists, and so that's where you're in a much better position to reinforce with your imaging centers that whole referral issue. It's much more challenging for us to do that. Let's see. Let me see. Let me take another look at that. Okay, this is about it's really about the CHDP PM160 data and the ability to capture, a great deal of the preventive screenings on children. We love the PM160.
We love
it. Now, how long it's going to last, we don't know. We keep hearing every year. In fact, I just had a talk with CHDP recently. It will be going away. We just don't know when. But while it's around, we love it and we encourage it. We
make
do.
Sure it's legible.
Yeah.
You read everything.
Yeah.
And submit with CMS 1500.
Yeah. Let's see. Does LA Care have a historical data capture form or process? That's actually a good question.
Data capture.
For the easiest one is
through the supplemental data, right?
So meaning if a member is reporting that they had a colonoscopy 5 years ago?
Right. Well, for those measures that are hybrid measures, if you make sure you record it in the chart, if it's part of the hybrid sample, we'll be able to capture it. So that's probably the simplest way is documentation in the record. The other, now for care, for childhood immunizations or adult immunizations, if the groups capture that historical data, they can enter the historical data in care, so that's another way we'd be able to capture it. For other ways, it may be challenging. I don't know if you could submit an encounter that's historical that you didn't actually, if you didn't provide the service.
If you have a supplemental data source, a database, a registry that you're using, reach out to us and we can work with you and our HEDIS compliance auditors to see whether that's acceptable.
Actually, that's
probably the best way to proceed.
So I think we hopefully we hit on those.
Mm-hmm.
Oh, okay. There will be a survey at the end of this that will pop up. We encourage you to complete that. We are, as a reminder, There are 2 additional QI webinars. Next week is LACC. And the following week, I believe, is CMC. The webinars are different. More than ever, we're realizing the lines of business are very different. So don't assume that it's going to be the same stuff, because I can tell you it isn't. And so we really encourage you to participate in all of the webinars for those lines of business that you participate in.
So one last question.
On the POR, do we need to focus on measures where the denominator is more than 30 members? I wonder if they mean less than 30? Well, we actually have a separate, I think it may have been less than 30. We actually have a separate strategy for low denominators. The thing is that even a small impact on low denominators can have a big impact on the actual results. The other thing is that you may not, even though a POR may say that if there's less than 30, you don't know what that final is going to be. And the other thing is, keep in mind that for the health plan, it's huge. Yeah, virtually all of, for Medi-Cal, we don't have any low denominators. Yeah, every denominator is big. Yeah. So, yeah, that's really, and the advantage is the low denominators. It's in one way, it's easy to reach out to those members. It's kind of a low-hanging fruit. So, yeah, that's the way I turn. Well, we're going to have to end. Thank you all for your participation. I hope you found it useful, and again, encourage you to fill out the survey. Thanks.
Thank you.